the CPR, for now.
Oh, sorry. Are we good? Okay. Got it. So my name's Deanna Diebold. I am a pulmonary doctor with sort of a special interest in the management of ALS, some of which is the management of excessive secretions. So we'll talk a little bit about that today. I have like a 10-15 minute PowerPoint presentation. Feel free to interrupt if you have questions, but hopefully there'll be plenty of time at the end also for questions. So there we go. So just a little cartoon of the salivary gland. So the parotid gland here back by our ears produces most of our saliva, joined by the submandibular gland here and the sublingual gland here underneath the tongue. We normally produce 1.5 liters, so 1.5 quarts of saliva every day. And we all swallow about once every minute, mostly without thinking about it, in order to control that saliva. Saliva has super important functions. It lubricates our food so that we can swallow it more easily, but it also carries a lot of immune globulins that contribute to oral and dental health. And people with reduced saliva with other conditions will oftentimes develop a lot of dental issues because they lack that function of the saliva. People with ALS tend not to have increased saliva. It's just that it seems that way because there is difficulty managing that. And so the swallowing becomes much, much less automatic. So the technical term is sialorrhea, which basically means drooling. And again, in ALS, this is not due to increased secretions. It's due to difficulty or inability managing the secretions. There's some very early treatment that we can suggest for people who have very mild symptoms. So foods that are sour or very, very sweet. You've maybe had that experience where you almost feel your salivary glands sort of squirt. Those foods do increase a little bit the production of saliva. So avoiding those types of foods may help somewhat. And then optimize hydration. So if you are overhydrated, you might produce slightly more saliva. Again, it's about 1.5 liters. It might be like 1.6 liters instead of 1.4 liters. It's not a huge amount, but every little bit counts. People who are dehydrated, their saliva gets a little bit too thick and then more difficult to swallow. So you want to find that sweet spot where you are optimally hydrated. Moving on to sort of, okay, the simple things aren't really working and we're getting into needing more support. We usually try to start with non-pharmacologic treatment, so not drugs, but other methods. So suctioning, you can get a portable suction machine that looks a little bit like this. It is not quiet or unobtrusive. You have to plug it in and turn it on, and it makes kind of a lot of noise, but then you can, instead of having to fill up Kleenex after Kleenex or a little spit cup after spit cup, you can use that suction in order to clear the saliva out of your mouth. Proper positioning, whether it's in a chair or in your wheelchair, can help sort of upright and a little bit forward with the neck, can make it somewhat more easy to swallow anything. And that would include your saliva. And then, I don't know if you've ever seen somebody with a soft cervical collar. Again, this is sort of a positioning thing where you can wear some support so that your neck doesn't go too far in one direction or the other, more in a neutral position to potentially make it easier to control these secretions. Moving on to medications, the ones that I would say we use most commonly are a group of medications called anticholinergics. So they target the choline receptor. Scopolamine patch is a commonly used one that goes kind of right here. It gets absorbed systemically and reduces secretion of the salivary glands. Robenol, which is also known as glycopyrrolate, can be swallowed or put through a gastrostomy tube or an IV form for people who are in the hospital, but it comes in a pill form. What's that?
I could jot anything down if you.
You're all right to keep going.
Okay. So these medications can be used to dry up secretions. They are not without side effects. So first of all, they can have sort of systemic side effects. They can cause confusion, they can cause constipation, they can cause urinary retention and difficulty emptying your bladder. So you have to be very careful, start low and titrate very gradually upwards. The other thing that happens is it's kind of difficult to find a sweet spot where you are controlling your secretions and don't have sort of a weird dry mouth feeling. And so some people feel like I'd rather just drool than have the dry mouth, or the other side effects that people get, the constipation, the confusion, and the urinary retention. The other thing that can happen if you thicken the secretions too much, whether it's through dehydration or through these medications, is that they become more difficult to swallow. And then if you're trying to clear them out of your airways, which we'll talk about a little bit later, sticky secretions are harder to get out of your airways. So you have to be super careful if you're using any of these medications. That said, we do use them just with a lot of caution, starting with a very low dose and gradually increasing kind of as needed and as tolerated. Botox can also be used for sialorrhea. And here you can see a little picture of a guy. This is an ultrasound probe that is telling the technician where the parotid gland is. And then this is a little tiny needle that has botulinum toxin that works locally to stop the production of saliva in these salivary glands. It's pretty effective. It is not associated with systemic side effects, although it does give people the dry mouth that is, can be a little bit irritating, but it also doesn't dry the secretions to where we worry about pulmonary clearance. It just is more of a dryness in the mouth. It lasts about 3 months. And then the salivary glands will start working again and you got to have it done again. But I would say we have people do this periodically, not never. Sometimes the salivary glands can be radiated. Damage to the salivary glands is a known complication for people who are receiving radiation therapy, say for a head and neck cancer. And so in certain people, we will use that kind of to our advantage. And a couple of treatments with radiation therapy will kind of zap, for lack of a better word, the salivary glands and shut down production. Drawback of that is that it takes more treatments. It's somewhere between 2 and 4 treatments. So it's not like 16 treatments. And it's usually permanent. So if you don't like what you get after Botox, you can wait 3 months and it'll sort of come back. If you don't like what you get after radiation therapy, that's what you get. Surgery is essentially never used in ALS. It can be used. They basically tie off the salivary gland ducts. And sometimes it's used in children with neuromuscular conditions or neurological conditions that make it difficult for them to handle the secretions, and they need really a very permanent, long-term, over years and years, control of the saliva. So it's an option, but really, from a practical standpoint, never used in ALS. So we're going to stop here talking about salivary glands and the management of that. I'm going to move on to the management of the lower airway secretion. So upper airway, lower airway. I'm just going to quick check the chat.
I was just going to say I could read that to you. Dr. Diebold, Laura asked if Botox to the salivary glands is something that's typically covered. Yeah.
Yep, I just saw that. I believe so. We haven't run into major problems with payers that I'm aware. It's a little bit of a black box for me, but usually I hear about it if there's trouble. And I don't hear about that. Any other questions? Okay. All right. So we'll move on, I think, to pulmonary secretions and chest congestion. So most people with ALS who don't also have some sort of intrinsic lung disease don't tend to have a lot of chest congestion and pulmonary secretions, which is a good thing because it can be difficult to control if you do have muscle weakness and chest congestion. However, chronic aspiration from difficulty controlling oral secretions can sort of constitute an intrinsic lung disease, so you're not completely off the hook. But many people don't have to deal with this issue. However, if you do, then you'll want some help. So any management of pulmonary secretions is made more difficult by a weak cough with the weakness of the chest wall muscles and the diaphragm. So as you get weaker, you have just much more difficulty doing that and generating any force to clear secretions from your lungs. So we can use sort of standard pulmonary medications in this instance if you do have difficulty with secretions chronically. These are associated with many fewer side effects because they tend to be inhaled medications, which basically are topical medications that you put on your airways. So there is some absorption into the system, but much, much less. So we use inhaled or nebulized steroids. So that's an anti-inflammatory that gets deposited directly on your airways. So if there's a tendency towards inflammation, that'll sort of tamp that down. There's a whole bunch of inhalers, Advair, Symbicort, Brio. You've probably seen them advertised on TV. They're usually used for asthma, but they can be used for any sort of chronic bronchitis. Nebulized steroid is Pulmicort or budesonide. There's only one, but it's basically the same thing. The bronchodilators, albuterol, Proventil, again, come in an inhaler form, which is super portable, and a nebulized form, which requires a little tiny nebulizer machine to deliver that to your airways, dilates the bronchial tubes, and helps make it easier to clear secretions. Some people find guaifenesin very helpful, whether it's for chest secretions or sometimes for nasal secretions. Guaifenesin is the generic name. The brand name is either Mucinex or Robitussin. This can be purchased over the counter. I would say the effect is usually very modest, but it is nearly completely without side effects. And so if somebody has especially nasal congestion or a little bit of pulmonary congestion and they want to try it, it's typically very, very safe, partly why it's sold over the counter. All right, moving along, I think. Uh-oh. There we go. All right, ways to kind of also help clear airway secretions. So this is an expiratory muscle strength training valve, which is kind of a new thing on the block. It's got early data that shows potential benefit. We don't use it a ton, but it's out there and it can potentially be of benefit. So this little clip goes over your nose, and then you put your mouth or your lips over this and you blow. And it's set based on pulmonary function tests. So you get what's your maximal strength, and then you set this to 50% of that. And then you do 5 reps of 5 blows, 5 days per week. Now, why don't you do it 7 days a week? I don't know. The idea is that if you do this, you might reduce the progression of weakening of your throat and tongue muscles. Again, not used a ton. There's not great data, but it's out there. And for people who are interested and motivated, it certainly could be done. Airway clearance, you may have seen these or heard of these. I'm not a fan of these in ALS because they require intact muscle strength. So they are great in people with intrinsic lung disease, chronic secretions, and intact muscle strength. What they are, it's a one-way valve that you blow against, a little bit similar to the EMST. But what you're trying to do with this is really generate more airflow that gets past any secretions that are in your lower airways. because if you blow against the one-way valve, then some of the air goes back into your lower airways. And that gets behind the secretions, and then you can use that to cough up the secretions. So they can help, but to the extent that weakness is the problem, they're much less helpful. So again, from a practical standpoint, not typically used in ALS other than very early ALS with a lot of secretions. So I don't know if this is going to play. Hopefully it will. Kat, maybe you can let me know if everybody else can hear it. So there is a vest that you will see in this and subsequent video that basically you put over your chest, and it pummels your airways to try to unstick any secretions that are in your lower airways. This, similar to the Aerobica, is very commonly used in people with chronic lung disease like cystic fibrosis and lots of secretions, and intact muscle strength. Because if the secretions are stuck really low, then you pummel the airways, you get the secretions to move, and then they can get coughed up. If you move the secretions around and you still have a really, really, really weak cough, it's going to be less beneficial. But I'm going to show it to you anyway, because sometimes it does have a role in ALS. So can you hear this, Kat?
Nope, there
No.
isn't audio. So if you pause it for a sec,
Okay.
and on your bottom of your screen or where it has, sharing options, there should be a more button,
Okay. Yep.
and you should be able to share audio.
Share sound. There we
Perfect. And then
All
try that.
The system consists of an inflatable garment attached by air hoses to an air pulse generator that rapidly inflates and deflates the inflatable garment. During a treatment, the chest wall is gently compressed and released, which creates airway oscillations and increased airflows within the lungs. Extra airflow allows air to move beyond retained secretions. Increased expiratory airflows combined with airway oscillations thin and shear secretions from the walls of the airways. The secretions are then moved towards the large airways where they can be cleared by coughing or suctioning. This type of secretion clearance therapy is referred to as high-frequency chest wall oscillation.
Okay. So that's the cartoon of the vest. Here is a picture of somebody actually using the vest.
Consistent therapy from start to finish, with minimal patient interaction and continuity of care across the continuum, from hospital to home.
Okay, you kind of get a little bit of a sense of what it looks like. There's the, whoops, sorry.
Start to finish.
There's the one that goes over the shoulder, and then there's a so-called wrap vest that really just goes around the chest. That's sometimes a little bit easier to get on for people with mobility problems. Okay, we're going to move away from the vest and move to what I think is actually the most beneficial for helping with airway clearance in people with any sort of neuromuscular weakness, ALS included, and that is breath stacking and a cough assist. And so the idea is, if you can have something else get air into your lungs and then have that get behind any secretions, and especially have a little bit of assist to get it out, that will help you better mimic the that you need to do to clear secretions. So the first one is sort of the inexpensive version, which is breath stacking. So I'm going to play this video and you'll see how that works.
Brad was diagnosed at an early age with limb-girdle muscular dystrophy. His ability to cough effectively is significantly compromised as a result of his neuromuscular condition. At best, his spontaneous peak cough flow is 80 liters per minute. Brad is able to improve his cough by first reaching maximum insufflation capacity beyond that which he can achieve on his own using the lung balm recruitment bag. The peak cough flow with lung balm recruitment improves to 350 liters per minute. Brad can further improve his cough efficacy with a commonly used manually assisted cough technique such as the caregiver-assisted abdominal thrust. First, Brad's position is assessed and safely optimized. Brad reaches maximum insufflation capacity with lung volume recruitment bag. The breath is held. At the command of cough, Brad coughs and the caregiver simultaneously initiates a single thrust applied inward and upward through the abdomen. Brad's peak cough flow with lung volume recruitment and manually assisted cough is remarkable at 560 liters per minute. An alternate manually assisted cough technique, such as the caregiver-assisted lateral costal compression, is possible if contraindications for abdominal thrust is or are present. Trevor was diagnosed with ALS, amyotrophic lateral sclerosis. He is able to optimize his cough by breath stacking up to maximum insufflation capacity using mouthpiece ventilation. The breath is held and followed by a manually assisted lateral costal compression technique.
Okay, so you can see in both of these cases, these patients have at least some bulbar function. So as mouth and lip muscles get weaker, this gets more and more difficult. But depending on the level of bulbar dysfunction, this can be of some benefit.
Brad was
Whoops. So this is the fancier cough assist device. And this can be used with a mask, as I think you'll see in this video. So this can be more easily used in somebody with a fair bit of bulbar dysfunction, to basically do the same thing that the breath stacking did that you saw there. So I'm going to play this video.
IE applies positive pressure by mask, mouthpiece, or artificial airway connector, inflating both lungs evenly. Positive pressure is followed by a rapid shift to a negative pressure to generate consistent peak cough flow of 300 to 600 liters per minute. The usual treatment pressures are plus 40 and minus 40 centimeters of water pressure. Studies have shown that the minimal effective therapeutic pressures are plus 30 and minus 30 centimeters of water pressure.
Hi, Chester. I'm Aaron. I'm your respiratory therapist. Pleased to meet you. I'm here to assist with your cough to clear your secretions.
When a tracheostomy is in place, it is best to perform MIE with an inflated cuff to minimize leak and enable the chest to reach therapeutic pressures.
Out. Breath in, cough out, out. Breath in, and cough out, out. All right, Chester, I'm going to deflate your cuff and put your cork back on your trach, and we're going to hear your voice now, okay? So your cuff's deflated, and I'm going to put the corking valve on. Can I get you to say hi? Hi. Perfect. I'm still here. You're still here. Excellent.
In the absence of contraindications, mechanical insufflation, exsufflation, cough capacity may be further improved when manually assisted cough is timed with an exsufflation phase. Glenn has Becker's muscular dystrophy. Prior to this hospital admission, for a condition other than respiratory infection, he worked full-time in accounting despite being 24-hour, non-invasively ventilator dependent. During his hospital stay, he naturally developed general weakness. However, invasive ventilation was avoided in part because of daily access to mechanical insufflation, exsufflation to clear the mucus from his lungs. Glenn was eventually discharged home with a personal mechanical insufflation exsufflation device to ensure optimal daily lung secretion clearance, reducing the risk of infection.
All right, so you can see kind of how that works. I should have described, so what it is, it's a super big breath that you get, whether it's through the trach or the endotracheal tube or a mouthpiece or a mask. And then it pauses for a second and then it actually reverses flow and it kind of sucks, which is a very weird sensation. but it can be super helpful if there's muscle weakness and stuff stuck in your lower airways, especially along with that manually assisted cough that you saw. So that is sort of the bird's eye view of oral secretions and pulmonary secretions and the tools that we have to help manage them in ALS. And I'm going to stop here and see if there's other questions.
Thank you so much, Dr. Diebold. There were a couple other questions that came in from the chat that I can read. One was, so do Botox injections work right away or only after about 7 days?
Oh, that's a super good question. I think I don't know that the delay is quite 7 days, but I think it's at least a few days.
Right.
Yeah.
And then the other question was, I take an expectorant with food into the G tube and wonder if that's helping very much.
So is the expectorant like a Robitussin DM? And if so, it may be. Again, the effect is very, very mild, but some people swear by it, and I never try to dissuade anyone from doing it because if it's helping, it's essentially without risk or side effect. So go for it.
All right. Were there any other questions for Dr. Diebold?
I'm just gonna. Oh, and somebody said, oh, that was you, Kat. Can you show what you take? Yeah.
We'll see if Vicki can, Vicki, if you can share a little bit more information about what kind of expectorant you're taking, that might be helpful too. But otherwise, I think this was super helpful. This is something that we've definitely been looking for a while. Oh, she says she's taking, yeah.
Medicine.
Yep.
So again, if it's helping you, great. There's really no reason to stop it.
Any other questions, anybody?
Is it funny if I have one?
Yes.
Well, no, I wanted to pick your brain a little bit about going back to the Botox. I feel like we've had people who get one injection and nothing happens, but then a second one is more effective. Is it really a question for you, or that's maybe more for PM&R who actually does it? But
that's maybe more for PM&R than actually does it. But I mean, physiologically, that would make sense.
Okay.
You know, if the dose isn't quite enough, or you know, there's some knocking back a function and then they get a second one on top of it, I think that is a reasonable thing to have happen. Okay. Yeah, and sorry, that's something I'm not nearly as familiar with as the pulmonary aspect of things. So I should have had Dr. Walk do that part of the thing.
No, see,
Yeah.
he'll be next. We'll get it.
Okay. Sounds good. Sounds good. All right. Well, I'm happy to, answer questions that come up. We can talk on the phone or email or what have you. Yeah.
That would be great. Well, definitely, if any other questions kind of pop up throughout the rest of the chat today, we will maybe send them by email. And if you have time, we'd love your thoughts on them. But otherwise, we thank you so much for your very, very precious time. We know that it's hard to get you on, so we're thankful that you joined us.
No problem. Nice seeing you. Take care.
Thank you.
Bye-bye.
It's great to see everybody.
Yes.
That was helpful.
Yeah, I think so. And I do want to, there was a couple people while she was talking that we would get some background noise. So then I actually went in and muted some people, and I did not mean that to be mean at all. I just, I wanted to make sure everyone could hear what Dr. Diebold had to say. So if all of a sudden you were muted and you didn't know why, it was me, and I'm sorry. But I hope you can get yourself unmuted if needed. Yeah, and then is Liz, why I'm not seeing, oh, she's there. Liz, are you with us? Maybe she's stepped away. Oh,
No, I'm here.
I said, I thought even if you don't go into detail, you could at least introduce yourself so people know who you are, and then we can continue through the rest of the group with introductions and any questions that everybody has.
Okay, sure. Yeah, I don't mind. Yeah, so I am Liz Stanley. I am the arts program manager for the ALS Association. And if you haven't heard of me yet, I've been sort of bombarding you with probably information about it. But if you haven't heard of it yet, I am creating the program called Creative Pursuits. And we have classes and events coming up, and I'm hoping that the program just continues to grow. So there's online and in-person opportunities. If you want, I can go ahead and share my screen here and just show you the list of what we have right now. So you can see what's available, and then maybe somebody or I can put